Welcome to the Scale CEO Leadership Series, where we engage with top healthcare executives to uncover the strategies, challenges, and innovations driving success in today's evolving industry. This series delivers exclusive insights from visionary leaders shaping the future of healthcare. Join us and subscribe as we explore leadership strategy and transformation at the highest level. I'm your host, Roy Bejarano. Welcome to, I think it's the 55th episode of our CEO Leadership Series with Dan Greenleaf, a good friend, a proven operator, and the head of Duly Health, which is, I think, the country's largest independent multi-specialty group with over 1,000 primary and specialty care physicians in 150 different locations. So, Dan, I've been looking forward to interviewing you, podcasting you, which is an actual new verb in our lexicon, for quite a while. So excited to get going here.
Yeah, well, thank you very much for having me, Roy, and excited to have the opportunity to share the Duly story and what we're up to. And so thank you.
So let's start where I always begin with CEO leaders, which is, how did you end up running Duly? What was the journey that led you to that position?
Yeah, that's a really interesting question, Roy. I would say first and foremost, it was unexpected. I wasn't looking for something like this. I've been a 6-time CEO and have been involved in from pharma to infusion to Medicaid-based businesses and now physician groups. And I've had a long-term partnership with Ares. And so Ares invested in Quorum more on the debt side than on the equity side. They invested across the entire capital structure when I was at BioScript, and we eventually sold that to Option Care, which was a home run. Quorum was a home run as well. And then after I left Motive Care, they invited me to participate as a operating partner / advisor. And I did that with them for 7 or 8 months. And then kind of in May of 23, they asked me if I would be interested in running Duly. And so that's by and large how it happened. And the interesting thing is, it's going to sound a bit maybe overly simplistic for people, but I do believe fundamentally these healthcare systems, it's all about the same things. There's nothing new, whether I move from an infusion business or if I was running a physician practice, the same priorities hold true. And I'll just share with you what those are. But the first is making sure you're committed to putting the right people in the right seats. And I've just done like a table of what we've done there over the last year and a half. And there's only, of the 25 top people in our organization, there's only 2 in the same role that they were in when I joined. And it's a big commitment. You have to get people involved. We use pretty interesting tool called Cultural Index, but it's the single most important thing you can do to improve the company performance is bringing in the right people and putting them in the right seats. And that's if you had asked me what's the single most important thing I do as a CEO, it's not about setting strategy. It's about the team you put around you and the commitment to that team you put around you. And what's interesting, I'll also say, is that I've gotten better at it over time. This time around, there just weren't really any misses. I've had misses in the past for one reason or another. But the second thing is voice of the customer. It's getting really the organization focused around that patient experience, right? What do we need to do to take friction out of the system so that our patients are having the best possible experience they can? And if you look at our net promoter scores, which are 70, which is world class. So in the era of, if you will, of a Netflix, of an Amazon, of a Google, these world-renowned brands, Starbucks, we're in that rarefied air. And and that carries into our Google online searches, that carries into our top box scores, which are 88, says that. So 88% of our patients would recommend a family member to our services, which is just
Was that there when you joined, or is that something you've built while you've been there? That remarkable patient satisfaction.
I would say it's been there, but we weren't highlighting it, right? We weren't explaining to people what the consumer experience was like here at Duly. And I will say we did make a very intentional move on our Google reviews initially, because they did not match up with what we were seeing in our top box scoring or what we were seeing in our net promoter scores. And just from a statistical standpoint, we get 32,000 reviews every quarter. So our net promoter scores from a statistically significant standpoint are there. So we did some very intentional work on our online reviews that, have moved our reviews to kind of that 4.8 range. But a lot of this was just making sure that the organization does not forget why we're here. And I remind people that if this was your mother, your father, your sibling, your children, your significant other, your grandparents, how would you like them to be? How would you like that experience to be? And everybody understands that. Like, I want this experience to be like this. And that's that's what we're committed to, is reducing friction.
Let's take a step back, Dan. For the public, and increasingly now that we've posted on Spotify and on Apple, we're everywhere. I have to always listen with two ears. I listen with the CEO ear, what would other CEOs think? And I have to listen with the public's ear as well. What would the public think? So let's ask a question on the behalf of the public. Why should the public be as excited about the Duly brand as us CEOs have been about the Duly brand for quite some time? I mean, from a CEO perspective, it's unusual to have that big a footprint in one state. And I know that primary care and value-based care really leads to that outcome more often than not. You really you want to understand your patient captive base. You want to be able to influence their decisions. You want to build a network. And all these things are really strengthened by a state-centric business model. But from a public perspective, what is Duly doing that's so remarkable that the public should really stand up and take note? And
one is, I told you about,
patients.
The consumer experience. And if you look at our net promoter scores, they're probably 20 to 30 percentage points better than a health system. So if we're at 70, the net promoter scores at the health systems are somewhere in the 40s. And not only that, the second thing that's most important, and you hear about this all the time, is access. So access. How easy is it to schedule an appointment with Duly? Our average scheduling time is 2 days. The health systems in Chicago, depending on the specialty, are somewhere between 8 and 90 days. So think about oncology. In some instances, there's some institutions in Chicago where a patient will have to wait 68 for an oncology appointment. So that's two. The third is cost. So and what does that mean? So what's not well understood is coinsurance. So people say, oh, I've got really good health coverage and I'm meeting my deductible, but guess what? The coinsurance doesn't go away. So if you're a patient and you get an MRI at one of the institutions at Northwestern, for example, it could cost you up to $4,500. In our facilities, it's $500. So why should I care about that? Well, you're paying 20% of that. So 20% of $4,500 is $900 versus 20% of $500, which is $250. And you think about the average wage or average family income in our country is $66,000, you should care a lot about it. And so the out-of-pocket expense in a hospital, like for a colonoscopy, is 10 times higher. And you don't have a better consumer experience. You don't have better access. The only thing you're doing is you're paying for this excessive amount of bricks and mortar. And then the last piece of it is just patient convenience. Come to our facilities. You don't come to us. We come to you. We have 190 locations. So imagine
how many patients do you treat across those locations?
1.5 million. And we do over, and if we include ancillaries, we're doing over 7 million encounters a year. So 1.5 million patients across those 190 locations. 5.5 million are just physician encounters, but well above 7 if you include ancillaries.
And so, population of Illinois is 12.5 million, so over 10% of the population.
Yeah, we have a significant footprint. So I think it's a little larger than that, but it's a big percent of the population.
That's amazing. So really bringing high quality care and cost effective care to the state of Illinois versus excessive reliance on large, bulky hospitals. And whether it's primary care or whether it's specialty care, just the long delays, the struggles regarding access and the costs, and the struggles regarding actual patient quality and patient experience. Yeah.
And I've got some great examples like the pipe fitter unions. Like we serve 6,000 of their members. We know the health systems in Chicago serve the other 12,000. We did a comparative analysis and it showed that our costs were 31% less. So think about so there's really, I've talked to you about this, Roy. There's only three payers in the US. There's the taxpayer, there's the unions, Taft-Hartley, and the employers. You know, those are the people that we are footing the bill here. So that 31% difference matters a lot. And particularly, you know, if you look at wages, right? You look at inflation, they're pretty close to one another, but you look at patient responsibility and then premiums on top of that, and the gap between what people get paid versus the amount of responsibility now they have related to their healthcare, it's obnoxious.
That's the source of tension.
Right. Better access, better consumer experience at a far cheaper expense, and we're more convenient. You know, like you don't have to pay for parking when you come to our facilities. You know, there's it's easy to get around and easy to get to, and we're in their communities.
So how much of this cost efficiency, so let me phrase the question a little bit differently. So you're there, you're driving down cost, and in theory, you would think fee for service for my specialty procedures is fine. It's outpatient. It's more cost effective than inpatient or health system like for like procedures. I don't need to worry about this value-based care thing. It's complicated. I'm going to leave it alone. But you don't make that decision. Duly is heavy focus on risk-based. How much of your portfolio of patients, the 1.2 million, is Medicare Advantage? 1.5 million, sorry. How much of the 1.5 million is Medicare Advantage? How much of it is risk-based versus how much do you think of that as fee-for-service?
So full risk in 2025, we'll have 105,000 patients. And they're basically split somewhere between MA and ACO REACH. So think 50-50. So roughly 50,000 for both MA and ACO REACH. But then we have another 300,000 approximately in some type of shared risk arrangement. And so I would describe those as partial risk arrangements, and those can be done with, commercial payers as well. But we do have a portfolio of risk arrangements that have worked, reasonably well for the organization. And we're all in on value-based care. We are absolutely all in. We believe it's a big part of our future. We've got the doctors organized around it in the right way so that, we've never been a RAF shop. I think some of the companies got harmed as they were kind of over-indexing on the revenue side of value-based care. So getting the RAF scores up, but we've never done that, or we've always done it appropriately. And so, our focus has been on the MLR. How do we drop admits per thousand? How do we reduce readmission rates? Are we getting to the patient? We know that if we get to the patient within 3 days of discharge, there's a 60% less chance that he or she will be readmitted. And our ED per thousands are kind of off the charts in a good way, but we're just spending a lot of time on that. End of life care is another one that we've seen instances where people are giving chemotherapy to a person that won't be around for more than a week. And these are all the kinds of things that we feel very strongly about. So that we're firm believers in it. It's gone well. We've got a great leader there. She's built out a great team, and we're making tremendous progress.
So you came from a single specialty experience in infusion, and move into a multi-specialty experience here at Duly. And I imagine heavy fee-for-service and infusion and move into a value-based care rich experience here at Duly. I'm interested what that contrast is like, and also whether a lot of the analytics that go into value-based care performance, like MOR, which is a measure of medical costs versus premiums, right? It's looking at actual performance, medical outcomes. I wonder whether engaging in all that analytics informs the portion of your business that's fee for service, whether it's just a smarter, higher IQ operation to do any portion of value-based care within a portfolio that also includes fee for service. Do you think about it in those terms? Are you seeing much richer analytics at Duly than what you were seeing in a similarly large infusion platform, just because it was single specialty, just because it was fee for service? Maybe walk me through that.
We've done a lot of work on our analytics, and to the point, one of the challenges we had when I got here, Roy, is people didn't believe on the value-based care side. They didn't believe in our analytics and our analytic capabilities. We've fixed all that. In fact, we had an offsite last week, and we taught, and the doctors there, we had 5 physicians there with us, and 2 or 3 of them are running kind of the value-based care piece of this, and they all said, we believe the analytics now. So Dana and her team have done an incredible job of credentialing the analytics so that the numbers and things we share with the physicians now are things that they believe that if they act on, they're going to see favorable results. So
and was that a long list of issues with the analytics? Was it late? Was it dirty data? Was it the wrong KPIs? What was some of the main issues with the analytics when you said it was?
I think there was, for example, patient attribution issues, like who is that patient attribute? There was issues around, what's happening related to readmissions, what's happening related to admits. So there's a whole host of things. It was just dirty data. And
so it sounds like a lot of black data where like missing information as well.
Correct.
Like with attribution, who's responsible, with readmission, what ended up happening to this patient, sort of missing answers to important questions. Okay.
Yeah, and we've got that now, and I think we've got kind of a best-in-class data set. We brought in some really, really incredible people from other value-based care entities that have really helped us raise our game. And to the point where, again, if you can get the physicians bought in on the fact like this data is legit, I believe in it, I will act on it. And that's kind of where we're at. I'm feeling very, very optimistic about what we're going to be able to do from a medical loss ratio this year. I just think, I will also say that, Roy, at the end of the day, for me, it's always about the patient. So I don't care if the patient is in infusion. I don't care if the patient is being picked up by non-emergency medical transportation. I don't care if the patient is being served by non-skilled labor in the home. It always comes down to the patient. What is in the best interest for him or her? And so when I look at like what we have, and we basically from cradle to grave, we've got, we can manage a patient through his or her entire lifetime. But at the end of the day, it's always about the patient to me. It's always about the patient. And as long as we continue to focus on it, regardless of the financial structures, we're putting the patient first. To me, it really doesn't matter. That's one financial instrument, value-based care, but so is fee for service. And we're running these amazing activation campaigns now. So what's an activation campaign? It's for a fee for service. Please come in for your mammogram. Please come in for your colonoscopy. Please come in for your wellness visits. So it's like we're doing this also on a fee for service side. Right.
I'm really interested in that balance between fee for service and value-based care. So I think of you as a plus $3 billion revenue business.
Yep, that's right.
Certainly small, large cap, as opposed to large mid cap. Like you're in another tier where most of our space doesn't actually exist today. And it's very interesting to speak to you because it's almost like you're pioneering into the large cap space on behalf of the rest of us. Your thoughts are really, really important and and they're guiding thoughts for the rest of us in the mid-cap space. So as you think about fee for service, I don't know if you think about it as 10% of the 3 billion or 50% of the 3 billion. And I'm interested to hear what the weighting is like, but I'm particularly interested in whether you feel like the work you do in value-based care elevates the work that you do in fee for service, whether some of the treatment plans that you get to calibrate in value-based care because they generate savings and savings generate bonuses, whether you then take that information back to a fee for service part of your business and say, let's change the treatment plan. The lessons you learn on patient engagement and patient management, patient visitation, patient readmissions, all this analysis that you're flowing through value-based care because you just can't get there without it on value-based care. You can run a pretty simple business in fee-for-service. It's quantity-driven,
Right.
and you want patients through the door, and that's it. As long as they're getting treated, you're getting paid. But you can't do that in value-based care. You really have to monitor everything in value-based care. So I'm just wondering, how much of a bridge is there between one side of your business and the other?
I think the bridge really occurs at the primary care physician level. And I think it's hard to exactly ascertain because keep in mind, we're dealing with an elderly population on value-based care, ACO REACH, MA, the patients are all over 65. So some of that, and I think although we still do regular Medicare, we're kind of disproportionately weighted now to MA and ACO REACH with our Medicare population. So what's interesting is it's a little bit of a difficult comparison because the cohorts are different. I don't know if that makes sense. That all being said, the patient is in the center of everything we do. So as we look at technology, one of the breakthrough technologies, believe it or not now, maybe you know all this, but is a bridge. We're using bridge for ambient listening. Well, that's relevant across value-based care and fee-for-service. And I really believe something like that is a game changer, regardless of the patient you're seeing. Access, guess what? Access matters, outreach matters. So the things we're doing on activation on the fee-for-service side, we've gotten such great results. Guess what? We're taking that activation platform and we're moving it over to value-based care. Because what we know in value-based care, if you're going to drop your medical loss ratio to best in class, the key is that patient gets in to see especially the high-risk patients, get in to see our primary care doctors once a month. And we know that if we do that variable, we'll get all the results we possibly can. So I'm just saying, what we're doing is the infrastructure and technology that we're deploying and best practice that we're deploying are I would say, crossover regardless of the patient that we're caring for.
So it's not reimbursement driven, it's principle driven, and you're saying, Roy, better is better. And it's bi-directional. Correct. What we solve over here, we solve over there. You did say that the different patient cohorts, and I'm curious to pick on that a little bit. I mean, you did say you have shared risk and partial risk with commercial payers.
Right.
To the extent that you don't think of commercial payers as fee-for-service necessarily.
And we do.
Some of them you do, but you haven't sort of labeled them as the fee-for-service demographic versus MA and ACO is risk-based. You've got enough at risk with commercial that it's more nuanced than that. Okay.
Yeah, so we've got a shared savings program that has 242,000 patients in it. And then we have a total partial risk that has roughly 63,000 in it. So we're doing some form of risk, I would say, on our commercial population as well. But we don't consider those necessarily the total global risk that we're taking on when we manage MA or ACO REACH populations.
Was dealing with commercials on those partial risk contracts efficient, inefficient, comparable to dealing with the MA program, the ACO program, or infinitely harder? How would you describe it?
I think that I would say that the MA and ACO REACH populations, there's a lot more clarity because you know what you're trying to get to, right? You're trying to get admits per thousand down. You're trying to get readmissions down. You're trying to get your EDs per thousand down. You're trying to move the patients into Part B where appropriate, and you're dealing with end of life care. I just think the goals are much clearer, I would say. Now, it's not to say these programs haven't worked for us, but they're not as structured in a way that provides a level of clarity that the ACO REACH and Medicare Advantage programs do.
Okay. Couple more questions on Duly. So state-centric, state-focused Illinois. I know in the past you've had national platforms, national footprints, single versus multi-specialty. Do you see big differences between I'm gonna focus on Illinois versus where's my national footprint? And do you see a big difference between multi and single specialty? And I know at the end of the day, it comes down to taking care of the patient, but just in terms of organization and complexity, difficulty, risk, friction, just the day-to-day management, a big difference between those two things?
I don't think so. I mean, when I think of doctors, for example, one thing I always try to tap into with any clinician is they're vocationally driven. They got into, they were the number one person in their high school class. They could have done, academically, they could have done anything, and they decide to serve humanity. I mean, these are really special people. And that goes for nurses and APPs too. And then they're hardworking and they're smart. And my experience with them is like other people, but maybe at a little higher level, is that they just want the management team to do what they say they're going to do. False promises don't resonate with them. And I call it the say-do ratio. And I also believe that to be trusted, you have to be trustworthy. And trustworthy is something that you do over time. It is a combination of competence and character. And I told them, listen, I don't expect you guys to trust me from day one because I've not proven that I can be trustworthy. But I will. And when I do, you'll see the difference that we're going to make in this organization. And so I don't really feel like there may be more complexity, in terms of managing a multi-specialty. I've got amazing physician partners, with Dr. Merrick, with Dr. Shetty, with Dr. Horscheit. I mean, I've really got, there's a whole bunch more I could also comment on, but we've got amazing physician leadership too. And then on top of it, we've got 600 shareholders who are physicians, and they own somewhere between 30 to 40% of the company. So there's a lot of alignment around what are the organizational objectives. And, as long as I believe that it's more about, like I said, the say-do ratio, it's more about us saying how do I reduce friction in your life? So not only for you, for your staff, for your team, but also for the patient. And that's what we're all coming at this from. I work for them, right? And I make that abundantly clear. I work for you. You do not work for me. Yes, I'm at the top of whatever the food chain here is, but I'm working for you. And I just think it's less about the technical aspects of multi-specialty, and it's more around are you oriented to the patient? Are you oriented toward the clinician? And are you showing that actually you're going to do those things? And, the other thing I'll also say is a best practice. It's very obvious to me, but I'm in clinics every other week. And I'm asking questions, I'm getting feedback, and I'm, some respects kissing babies. But at the same time, they know if I go in to see them and they give me feedback on something we could do better, I act on it. It's not a drive-by.
So
it's not ceremonial.
So given all of that, the future of Duly 5 years from now, 10 years from now, relative to the future of Optum or the future of a large health system. I recently interviewed Scott Hayworth, who built and sold Caremount into Optum, a large multi-specialty in New York. How do you think about Duly from a 5 to 10 year perspective? What changes that's unique to Duly?
Yeah, so first of all, I also want to point out, we have quite the ancillary products as well. We have 5 or 6 ambulatory surgery centers. So, and the busiest in the entire state of Illinois, in Lombard, where we do 22,000 procedures a year. We have 11 imaging centers. We have 30 places that we do lab draws. We have 58 infusion chairs. We have 40 sites where we do physical therapy. So we're a hospital without walls for all intents and purposes. So if you ask me, like, where do we go? I mean, I see a company that, could achieve, $5 billion in top line revenue and $500 million in earnings. And evolving into things like direct to employer. Like if you know that your costs are a tenth of what a institutional's costs are going to be, and we know this runaway premiums are not, and the runaway cost of families is not acceptable any longer. And you can't just continue to have this arbitrage. A company like us that scope, scale, size can do everything with the exception of, like, we're not going to do heart transplants. We're not going to do, complex neurological care. We're not going to do complex cancer care. But basically everything else we can do. And we can do it for a fraction of the cost with a better consumer experience, with better access. So we can do all those things. Why wouldn't we contemplate direct to employer?
I was going to say, you mentioned the unions, you're of scale. Any large employer in Illinois, I would think, would be knocking on your door.
And I think that evolution is happening very quickly.
We just spoke down to the head of benefits at Disney for 20 years.
Yeah.
And she recorded a wonderful podcast. We're about to publish it this week on what it was like to be responsible for 250,000 lives. And she went into great detail on the Disney parks in Orlando, the 60,000 lives there, and dealing with different health systems. There weren't that many in Orlando. There was 2 of them. And getting much better outcome using value-based care, actually ahead of commercial payers, designing their own value-based care program. And it just, she raised the question, and she might as well have been talking about Duly. She said, why isn't a large multi-specialty MSO going more direct to self-insured large employers? The payer is not truly a payer. It's simply a middleman entrusted with the role of doing what self-insured employers and large providers are more motivated to do, which is to get it right. As opposed to just raising premiums exponentially,
Correct.
Actually solve the problem of great care at the right cost.
Yeah, and instead of, like, the payers over-indexing on institutions, which we know they do in Chicago, so they give inflated rates to institutional care, which we know isn't ever going to solve the premium problem, because what institutions are going to do is they're just going to build more bricks and mortar. And that's not, like, it's not us paying for the bricks and mortar isn't in the best interest of anybody in this healthcare system. Decentralized sites of care is where the savings are.
I'm going to introduce you to her because I think you'll get some value out of speaking to her and the experience that she had.
And on the MSO front, yes, too. So if you're going to ask me, like, how do I continue to expand in Illinois and how do I expand outside of Illinois? We've built, since I've been here, best-in-class revenue cycle management processes. We've built best-in-class centralized contact centers, decentralized central nurse triage, decentralized scheduling. We've built best-in-class technology. We've partnered with people and have done that. We've got best-in-class procurement processes now too. So the things that we do, behind the scenes, we're best in class at. And, we think that part of our business is, we can replicate that with other people. And so I 100% agree with her point of view on the MSOs too.
Do you, given all the opportunities that AI presents in the marketplace, I now count, I don't know, 20 to 30 AI vendors, discrete AI vendors that we do business with at scale. And I imagine that all the MSOs out there the number of AI vendors is growing, not shrinking.
Right.
Are you bringing in-house AI expertise just to manage the opportunity? How do you think about engaging with AI solutions that are evolving almost on a daily basis?
Well, we're big believers in proof of concept. So as I mentioned earlier, a bridge, we did an AI pilot with ambient listening. And Roy, I'm getting notes from physicians around, a product that I have never seen before. One of the problems with, technology is I think a lot of technology was just bullshit. It's like, because we're in the business, you and I are in the business of productivity. The business of technology was subscriptions. They don't care about productivity. All I'm trying to do is get more and more people on your service. And I said this a year ago, AI might break that paradigm, that actually we're going to have products that improve patients' lives, that improve physicians' lives, and improve the physician experience. And we're seeing it. It's amazing. And then I also think there's significant opportunity in just automation and sophistication when it comes to revenue cycle management as well. I think, you think about IVA, interactive, right? Voice assistant, that's already AI, but I think that's going to continue to evolve and become more and more sophisticated that, it's just going to take a lot of pressure off of what our clinicians do. And ultimately what I want and what I think the promise of AI is that our physicians and our clinical teams and our management teams continue to get more focused on that patient experience, because all the other stuff like charting and other things like that create so much dissatisfaction becomes a non-event. So, and then we decentralize all the non-value added things, or centralize the non-value added things, and remain central or decentralized in the value added things, which is interaction with the patient. So I think we'll continue to pilot. That's how we do everything. We beta site, we pilot. If it works, we go. And that's where we are with kind of a bridge right now. That's what we did with Tap to Access. We piloted it, and then we just went out with it. We're piloting some automation tools and AI tools and revenue cycle management works. We're going full bore with it. And so we're being very targeted and again, but if we see it working, we'll move faster than anybody once we see it working.
It's interesting that you started with ambient. Was that sort of scribing and medical assistant AI sort of in practice, in the consultation, note taking?
And if you look,
augmenting the patient,
right,
the clinician's ability to be productive, is that seems like a low risk place to start, because all the notes get reviewed and audited, and it's a pretty common place for a lot of provider groups to start. And it sounds like that has been a success. Yeah,
it's been a home run. And beyond what I had anticipated, because you just never know until you pilot it. But the emails I'm getting from, I say a fastidious group of physicians has been very, very positive. And if you look at there's a few things that drive clinical dissatisfaction. One of them is a lack of autonomy. And that's something that nobody really does better than a physician-directed practice like we are. I mean, the physicians are here. We do engagement surveys, and they always say autonomy is number one. But the other side of it is they call it pajama time, Roy, and it's the amount of time that they're spending, coding,
back home,
charting,
on the laptop.
Right, after work. And it really, from a clinical satisfaction standpoint, it is the issue. And this was one of the things that people really didn't take into account with EMR. It's, I think when Epic and the other products came out, it's like they skipped a step. And what step did they skip? What's this like on the consumer who actually uses the product?
They didn't automate anything. They digitized everything, but they automated nothing.
All it did is, and I asked physicians, since we've installed our EMR, is your life better? No. So, and it's unequivocal. So it became like a necessary, I don't like calling it evil, but it was necessary. But I think like with products like a Bridge, there is an opportunity to really unlock that physician experience again and get the care teams back into what they love to do, why they got into this in the first place, which we get to care for people. We get to make a difference in this world. And I'm very bullish on AI right now. And I said it over a year ago to my team, like this, they give me a hard time because I know the game that the technology companies play, subscriptions and low value and get you hooked on their product. And then you can't get it. You can't get out of it, even though it, because you're subscribing and, doing system changes are so complicated. And I said, I think most of the technology companies are just bullshit. They haven't really added any value. They've created work for our teams and they did a good job of selling it. But with AI, I really think like the game can change and actually better patient experience, better clinical experience, better life experiences for people.
Okay, so it's exciting times in technology. It's exciting times for Duly. You're going to go to those employers and you're going to get a lot of business because you're going to get rewarded for building a much better platform that keeps patients happy in a cost-effective way. When you think, taking a step back from a macro perspective and thinking about US healthcare and maybe even relative to global healthcare, what do you worry about? What do you think about in the industry starting in the US that you think is a cause for some concern? Is it different ownership groups? You're currently part of a somewhat institutionally backed, Ares is involved, right? An owner, a backer. You've been part of private equity backed groups in the past. I don't know, you have public market expertise as well? I think I recall.
Yeah, I've been two public CEOs, sold a public company.
Yeah. So you've done the public vehicle, physician ownership you're experienced with. Obviously, the nonprofits are out there. Is it different ownership groups getting too much control and influence, too little? Is it monopolistic power continuing to maybe cause a little bit of, if not a lot of harm across healthcare, whether it's the payers or the health systems that are sort of beating up on the other constituents because they have too much leverage? Is it drug pricing in the US that continues to cause friction? Is it payers running into trouble on automated claims? Is it government institutions? The new administration, RFK Jr., will he or won't he end all vaccines for everyone? As Dan Greenleaf goes to sleep at night and thinks about the health of our industry, there's lots to be excited about. What do you worry about?
Yeah, and I'm honestly more concerned about the health of our country. And what's in the best interest of your mother, your father, your siblings, your children. That's what I think about.
You don't want to bring my mother into this because she'll drive everyone crazy.
That's all right. I've known people like that. I do think like monopolistic power is a problem. Again, I go back to who are the payers? Employers, right? Taft-Hartley, unions, you and me, taxpayers. That's it. We are the payers. It's not the insurers. And I think about like the monopolistic power they have in Chicago, where they're, one of the companies is 65% of the market. And
it's pretty common across all states.
I know.
And
the reserves are dollars higher than comparable insurers like United or a Cigna or Aetna. And then, their execs are pulling in $90 to $100 million. And we've got a Medicaid product that's underfunded in the state of Illinois. And I don't like, it doesn't add up. It doesn't, I think that I look at what Doge is doing and the things they're uncovering.
I was just about to bring up Doge. Amazing.
Yeah, the things are uncovering. And I think the insurers, what is their value proposition? I don't know, honestly. What is it that they're doing to disrupt healthcare? What are they doing to innovate? What are they doing to drive greater care?
They were supposed to be organizing it. I'm not sure if that happened.
Right. And that's unclear to me. I'm like, I'm all in. You want to partner with me and we can do these things together? I'm all in. So we've got that. Then we've got pharma. And interesting enough, I was in pharma for about 15 years, and the first company I worked with was Shearing Plow, which I did for 10 years. And we were the first company first one to do direct consumer advertising with a product called Claritin. And we drove so much utilization, and we basically doubled the market.
I was one of your victims.
Yeah.
I was definitely a consumer.
It's bananas, because we knew that 60% of the patients who went into a doctor's office with an allergy would ask for a specific product. So we fed it to them. So I do believe, when I look at the media companies that, pharma companies are spending $15 billion a year on advertising. And, every other commercial, I had to turn off the Olympics because every other commercial was a pharma product, right? And I struggle with this view of like, well, they shouldn't be able to direct to consumer advertise, because there's only one other country in the world, that allows that. It's New Zealand. So there's only 2 countries in the world, because I do believe like an educated consumer is a better consumer. And if a consumer, that all being said, the misallocation of funds, and this is what it's all about for me, the misallocation of funds that are going to insurers, the misallocation of funds that are going to pharma companies, and the misallocation of funds that are going to institutional healthcare is the problem. Where, if you take doctors out of the mix, you'd still have 92% of the dollars are being spent. You look at the 1.3 trillion we're spending on commercial, 50% of that goes to hospitals, who I just shared with you are 10 times more expensive, without better consumer experiences, without better access, without better outcomes. And I'm not saying there isn't a place for them, because there is. Complex neurological disorders, complex cancer, trauma, right? Organ transplants. Those are all fine. But this nonsense of like it's just such a misallocation of funds, Roy. I just, that's what keeps me up. It's like, and we have to fight it. And fortunately, Duly's large enough, has the track record, has the scale, that we actually can go out and do something about it.
That's amazing that you're making, look, at a state level, you're making a huge difference.
We save the state $1 billion a year coming to us. Between Medicare and commercial, $1 billion a year. We save the state of Illinois.
I can empathize a little bit. I was the largest ASC management company in New York for a while, so I didn't know what it felt like to save your state billions of dollars. Right. It's a good feeling, and it's a good example to the rest of the country. I do think Doge is very focused on administrative dysfunction.
Right.
Payments going to the wrong places. How much of it is accurate? How much of it will get fixed? These are all subjects to debate. But in terms of what their core mission is, it's administrative dysfunction. I do think once you clear all that dust, you're still left with stuff that Doge is not focused on at all, nor should it be, which is who's going to solve for monopolistic behavior? Who's going to solve for the payer community not necessarily working in the public's best interest the way we would like them to? Avoiding premium inflation by focusing on quality and cost outcomes. Who's going to represent employers the way they'd like to be represented? Who's going to drive patient satisfaction scores? This is not Doge mission, right? So we still have a lot of work cut out for us. And I think it's interesting that, and I've said this before, we are living in a time where, change is afoot. Everything is being questioned, everything is being looked at. And I think that's not an accident that that's happening now. I think a lot of that is driven by new technology. Even podcasting this is all new technology infrastructure. Anyone can have a media company today. That was not the case 10 years ago. So we would have had to hire cameramen, build buy broadcasting rights, get a place on some kind of cable TV. Thinking about cable TV, well, that was the first revolution in media in the past 20 years, right? We've moved on from there. Everything is cable TV now. So I think we still have a lot of work cut out for us in healthcare. I have a question for you on global. So you've built a lot in the US, and you have tremendous case studies in what works and what doesn't. I would think that the rest of the world is salivating at the prospects of learning from us, because we have this beautiful, large, somewhat homogeneous market that loves to experiment within its homogeneity. So there's no better, as a CEO, you know that there's nothing better than having a large sandbox where you get a lot of toys.
Yeah.
And you get to build things and then rebuild them. So the rest of the world, if you're Belgium, you don't have that.
Mhm.
You don't have a 350 million populace with 50 plus states that can try 50 different ways of solving something every day.
Mhm.
So here you are, you're Dan, you've got this wonderful platform. Do you look at other countries and think, what if we expanded overseas? When does that conversation start?
Yeah, I think, part of the issue with saying that is, on a per capita basis, we spend more money than any country in the world.
We don't have a money problem in health.
Right. And we get the, frankly, the worst health outcomes of virtually any industrialized country in the world. I think that one of my challenges with that is like, who am I to say, like, what's best for you when we can't even get our shit together?
I love that you said that, because my reputation is growing now that this podcast is starting to really pick up with the public. I'm known for this amongst CEOs, but soon, hopefully, if I'm going to be known for anything, I want to be known for this. That is a misnomer, and I hope that I can redirect you after this podcast. We have the worst health outcomes because we have one of the worst health. And it's not English, but you follow what I'm saying. That's not the same as the worst health care. So we should never confuse obesity with the amount of time that our physicians spent in medical school.
Right.
They're not the same thing. So we should never confuse lack of physical exercise in southern states, I'm not talking about Colorado, with the amount of success you've had in value-based care, coordinated care, and measured outcomes.
Right.
Now, we have what I call them foibles. It's a little cute. We have monopolistic power that needs to be unpacked. I don't know that United needs to stay United. I have my doubts. I'd like to see 5 different Uniteds, not one. Like, do for them what we did with the Bells. I think that day is coming, by the way. So we have our work to do. But we shouldn't confuse that with how much work has already been done relative to other countries. I'm here to say loud and proud with an English accent, but you'll follow me. I've been here long enough. I've been here 30 years. I get to say that we've done more than every other country combined, bar none. If you look at some of the stats, I mean, I'll share with you one of my favorites.
Are you going to show me the NHS data?
I'm going to show you. Yeah, I do have NHS data, and it's horrible. But let me show you this one. This is the number of healthcare unicorns by region. That's how we look relative to the rest of the world, right? It's not even close. This is the entire rest of the, well, it's not the entire rest, it's just Europe and Asia, but that's most of the world, right? And certainly in terms of population. And so just healthcare startups that do well, we dwarf the rest of the world. Now, diabetes, we don't do well. Obesity, we don't do well. Physical inactivity, we don't do well. But as soon as you get into so life expectancy for us, this is what you were talking about, outcomes, right? But that is a function of our health. Expenditures, we've bent the cost curve. Every other country is failing at the cost curve right now. We bent it in 2009. We have something to teach them. They want to know how to bend the cost curve. They don't know how. Let me show you a few other interesting stats. This is all publicly available. We built it. It's called our global dashboard. Breast cancer survival rates, highest in the world. Lung cancer survival rates, highest in the world. And you know this, intuitively know this. When you're really sick, you come to America. Liver cancer, I think we're 3rd highest in the world. Heart attack, myocardial infarction, mortality rates, we actually score highest in the world. So for post-heart attack. We have 2 different countries really in America. We have low heart rates, low heart attack rates, high heart attack rates. 2 to 3 times higher in these states.
I recognize the state there.
What, yours?
Yeah, Colorado.
Right. Oh, Colorado, okay. So some other interesting stats here. How we spend our money differs from other countries. How much we spend on drugs? This is a problem. We're spending 2, 3, 4 times more on drugs. Equivalent, comparable, perfectly comparable drugs. This is a problem. So that we shouldn't teach the world how to negotiate drug pricing. That's for sure. But other interesting stats. Yeah, let me just organize. Patient wait times, some of the lowest in the world.
We probably
Patient-
have the lowest in the world at Duly.
Patients, right.
Yeah.
Excess reliance on hospitals, Japan is crazy. This is not a good stat. You know, Germany, overbuilt, over-reliant. France, over-reliant. We're efficient. Physicians and nurses, there's your NHS. Physicians per 1,000 people and nurses. This is not where you want to go where you're sick. This is us. Almost twice as many nurses. Right? This is called underfunding. This is what single payer does to you. It cuts off the capital right there.
Well, it cuts off the entrepreneurism. It cuts off model breaking, and then you have a unionized workforce. Not that I have anything against unions, but it's not the place you look for innovation.
Look at this, hospital admissions. If you're Germany, you sneeze, you're going to hospital.
That's amazing.
Almost three times more per 1,000 people.
Incredible.
You sneeze, they send you to a hospital. Why? They don't have outpatient. They never built it. By the way, China, zero outpatient, nothing. It's all hospitals. Well, we need to insert China into this because it's one of the most interesting comparisons. It's another one of the themes that I'm becoming increasingly, hopefully, thankfully, recognized for is I can't stand who we've been compared to.
Yeah, it's very good. This is excellent.
Right.
A lot of this stuff is very, very helpful.
EHR.
I got a little story about China. Hopefully it won't cause me to get a cyber attack.
Hold on. Look at this one. This is one of the most important ones. EHR adoption. South Korea, United States of America, lead. Best in class. Japan, 70%, almost 30 points less than us. European Union, 86%. I want you, Dan, if you leave this podcast with one thing, it's the knowledge that we have so much to teach the rest of the world on healthcare as an industry.
Oh, very helpful.
Okay. Anything else that you want to cover?
No, I just think there's two other things that when you asked me about healthcare and some of the, expenses associated with it, I'd say one is just consumer awareness is mind blowing. Like when I talk to everybody about coinsurance, and it's incredible for me to see the lack of awareness. So like if you get a colonoscopy in an institution, it's $14,000. You're going to pay 20% of that. If you get it with us, it's $1,400, and you're going to pay 20% of that. And it's incredible the lack of consumer awareness around these issues. Mind blowing.
What about consumer awareness about personal health?
Yeah, I think there's a lot going on there. I've done my DNA sequencing, just found out that I have high risk for heart attack, and I'm doing preemptive work on that now. And I think there's a lot of tools out there that could really elevate and improve outcomes because people know about the likelihood that he or she is going to have something that's, is not unusual, but it's not typical either. So, and the only other thing I would say, site neutrality. I know legislations they've tried to pass before. And what is site neutrality is if you get you're going to pay for a colonoscopy in ASCs that you're going to pay in a hospital. And that would really change the game and would save billions.
Efficiency in the market as opposed to strange imperfections.
Correct.
Dan, thank you for your time
Thank
today.
you so much, Roy.
I love the
Always a
conversation. I
pleasure.
hope you had fun.
Thank you. It was great.
Take care, my friend.
Bye.